And so one of the things, that I think, I just saw this, if anyone has copy of this, there was an article on HPV-associated installation. So I think that's a very important area to focus on, both in LGBT communities, but also more generally. Not only anal dysplasia, but then we also have head and neck cancers that are related to HPV. And so I think this is a really unique and important area. And some of the first studies of young folk, specifically Black and Latino MSM, was published in this journal. But that intersectionality between ethnicity, race, and HPV exists, because we know there was some recent data that suggests that the HPV vaccine, the subtypes of HPV that were in the vaccine are not commonly found in African American women, for example. So some of the developmental studies, which were done in more foundation of white women, there's a gap there. It's very preliminary data, but if that's the case, we need to have representation in HPV and other studies with African American community members. Similarly, we think of the lesbian community having higher rates of overweight, obesity, metabolic syndrome, and how about the intersectionality with African American lesbians as well. Is that additive? Is that synergistic? What are the drivers of that? Moving to methodological, I'm kind of obsessed with networks and network analysis, and so I think that one of the difficulties with LGBTI research is that communities tend to be smaller, and so there's a lot of potential for contamination, whether it be an intervention study, and people are referring others to the study. So knowing what parts of the community are in which studies, cross arms, even epidemiologic studies, significant bias if the sample is based upon a group of people that know each other, okay, or otherwise. Number 3 was training and increasing cultural competency of researchers, providers. I think this really is something, we're kind of in an echo chamber here, but I think we really all need to go to other institutions and places that do not have kind of top-down sort of training, cultural competency training for providers, for frontline staff, because that's tremendously important. University of Chicago, we have started a university-wide diversity initiative, and then within the Biological Sciences Division, we have an added one. So we're really focused and intent on promoting not only young researchers from sexual minority and other ethnic racial minority groups, as well as gender minority, but also making it culturally competent across the institution. Number 4, effective ways to engage with LGBT health research and advocacy communities. And one other thing about the training, there are opportunities to develop research around shared decision making, and so we have a grant in the HRQ that's going to be looking at that. Hopefully that will be funded. The next one was effective ways to engage with LGBT health research and advocacy communities. I think obviously CPR and other kind of high-intensity community engagement strategies, the ability to increase the number of community members that are part of the research idea. The scientists can kind of form the ideas, but as much as you can, involving community approaches to those ideas, especially that's not well represented in academia, such as Black and Latino community members. And then finally, effective ways to enhance communication between the NIH and LGBT research community. I think we're doing that right now. Certainly there are technological ways to do that. There are social media and other kind of non-traditional conference mechanisms to do that. But I think we have a fair amount of advocacy, and there are a fair amount of LGBTQ members within the NIH as well. So I think my hope is that that synergy will kind of keep this moving forward. Thank you.
There are some common themes that are emerging, but specifically one of the first points you made about the need to look at anal dysplasia, how it progresses. So NCI is just about ready to launch a very large trial to assess whether the treatment of the precursor lesions will reduce cancer in this trial's post. I can't tell you what the active stands for. I'm sorry to say, but it is getting set. Maybe some. Thank you.
Okay, well, our last speaker that we'd like to invite up is Dr. Sarah Whitten from the University of Cincinnati. She is an assistant professor in the Department of Psychology.
Thanks for including me in this listening session. Just to give you a sense of the framework that I come from, I am a clinical psychologist, and I direct the Today's Couples and Families Research Program at the University of Cincinnati. And so my research is really interested in couples relationships and how they can promote or hinder health and mental health of both the individuals in the couple and children that they may have. So that's definitely the perspective I'm coming from versus the traditional LGBTQ health researcher. And so it may be surprising that what I really like to see get some priority at NIH is research on understanding and supporting healthy same-sex couple relationships. And I think this is important for a number of reasons. First of all, given the historical and current social discrimination and non-recognition of same-sex couples, this really represents one of the ways that the LGBT community has suffered the most, in my mind. It's a lot harder to put yourself out there, to see a relationship, to find a long-term partner, and then to maintain that relationship and reap the benefits from it that heterosexual individuals take for granted in terms of the legal and tangible benefits, also community support. And that's especially important given that there's a wealth of data suggesting that marriage and other long-term stable relationships are very powerful promoters of health, mental health, and living longer, being more satisfied with the life that you're living. So even currently, as the legal climate changes somewhat, there's data from California that is one of the more supportive states that still shows that adults who identify as gay or lesbian are in committed long-term relationships at a lower rate than are heterosexual individuals. So that, to me, represents a pretty powerful sort of broad-based foundational kind of disparity that has many implications. And so I really think that efforts to promote same-sex relationships and healthy ones are really important and a viable way to reduce some of the disparities that we've seen. And I think that most people generally wouldn't argue this. But what gets tricky really is, here's funding from NIH around this. Right now, and there's probably not too many couples researchers in the room, but just in the past 10 years, couples researchers really lost their home at NIH. For a while, it was NIMH would support research that had as its end goal healthy couple relationships. And then that ended around 2003 or so. And then NICHD sort of picked that up, as long as it was really tied tied to child outcomes, which is really not difficult. The marital relationship, the couple relationship is often one of the most proximal predictors of child health. But just in the past few years, that's really shifted away to the NICHD priorities have shifted away from that. So I'm just kind of taking this opportunity to get up on my soapbox here and have someone listen to me from NIH to just advocate for that, in particular for same-sex couples, perhaps research that considers the health and stability of the couple relationship as an end goal might be important to start prioritizing. And I've got a couple reasons for that. Right now, currently, the couples research that is being done is very specifically targeted at hot diseases or mental health. So, let's say couples treatment for bipolar disorder or severe anorexia. And what's great is that those interventions, by the way, are doing fabulously well and seem to be much more effective generally than individual-based interventions. But that's sort of a treatment of an existing problem approach, and I think here we'd be much more benefited by a preventive approach. And it made me really think about one of the NIH missions that we put at the beginning of your talk, which is to promote healthy living. And I think in general, it seems that people have as aspirations in a sense of what their healthy life might be if it turned out the way that they wanted to. Part of that would be a long-term committed partnership. We see even as marriages on the decline all over, especially in Europe, still Europeans, over 90%, at some point in their life live in a long-term committed relationship. So these are important, and they're stated from LGBTQ youth, indicating that 85 to 90% plan to live in a marriage-like relationship or hope to as adults. So I think this is really relevant and an important social context to be thinking about the health of the LGBTQ community. So I guess that's my main question. Can we do some research that's really just where that is the end goal versus really having to tie it to HIV outcomes or other diseases. And I think the plot of which areas are getting funding was pretty striking of the diseases that should be getting funding. I'm not saying that they shouldn't, they're devastating and all that, are just getting the bulk of the funding. But I wonder about just more broad-scale interventions that might have slower but more broad effects on the well-being and health. And so that's my main. And the second one, just to add on to that, is if we want to, as healthcare professionals, mental health care professionals, try to be part of efforts to promote healthy, committed relationships, then we need to first know what those are and what they look like among same-sex couples. And that's a really tricky place to be, because there's some data that really is showing that couples are couples in a lot of ways. Some of the core processes, being able to communicate healthily and resolve conflict healthily, really hold true for many different couples. But we also don't just want to force a heteronormative framework on same-sex couples. So I think it's important to also be trying to prioritize some basic research just to better understand what are the predictors of healthy, long-lasting relationships in same-sex couples. And there's just some beginning interesting findings just of interest around this, and just, well, monogamy seems to be a pretty definitively important piece for heterosexual marriage. We recently found a study that that's not necessarily the case among male same-sex couples. So there's some specific information about what kind of monogamy agreements men can have that we are finding are associated with better outcomes than others. And so that's important information for people who are working with male couples to know, to be able to disseminate them. So that's just also a little further, just the basic research looking at the processes in the same-sex couple. Thank you.
NIH is either not supporting or no longer supporting certain types of issues. Again, I'll take you off the focus. That your experience and sympathy, your experience together with those of the many comments. Is that investigators are reluctant to put in application because they have learned or have heard that a particular institute or center is not favoring a type of research? Or is it that you have been waiting, have been waiting for specific funding opportunity announcements, assuming that absent that there's real interest, or a third possibility that you and your colleagues are putting in applications and they have not failed? Which of those three buckets would sort of define your colleagues?
I would say all three buckets, probably. I think NIMH is really switched, has explicit statements about what the outcome variables can be, and relationship satisfaction, relationship well-being is not included in those. And ICHD actually a couple of years ago shifted their website and their policy had some explicit statements, couple relationships and couple relationship education programs and stuff are explicitly not in a funding priority. Yes, there have been applications that have been focused on that have been based on some those shifts in the priority that have, although gotten a high scientific review score, have been the council has elected not to fund based on those shifting priorities.
So absent NIH, what are the other agencies that work like this?
That's a good question. Currently, I have some work supported through the Lesbian Health Fund, the Gay and Lesbian Medical Association. Smaller.
Well, I'd like to invite you, reserve about half the time for people from the audience to come up. So we have about another half hour to take comments. If you want to come up to the microphone and line up just over here. Come up and we'll get to as many as we can. So I encourage everyone to try to keep their comments as brief as they can. And while people are coming up, I'm going to ask a question that sort of stems from some of the discussions that have occurred so far today, which is, one of the things that I think about is, bringing a conference like this together, supporting multiple faculty, supporting community engagement, supporting translational research requires a tremendous amount of infrastructure, which I've been blessed and Northwestern has been supportive to the extent that they can. But that's the thing that's typically supported through center funding in the other areas. And as I think about that, I think about the Institute NIMHD, National Institute for Minority Health Disparity, which has funded centers for men's health, centers for health of racial ethnic minority populations, but has not made a call for centers for LGBT health or sexual minority populations. And I think centers like that could play a tremendous role in catalyzing the field, training the next generation of scholars, accelerating the pace of scientific discovery, and can also serve as a conduit between the community and NIH, which is one of the stated objectives of the listening session. And I know that NIMHD, along with NICHD, were joint in charge of sort of leading the initiatives around LGBT health. But when we saw your presentation today, it was clear that NIMHD was funding less than 2% of LGBT-related applications. So if you are able to make a statement about sort of what role the Minority Health Disparities Institute plays in LGBT health, and is LGBT health an explicit priority of theirs?
So a couple of things, and thank you for the question, because it's something that comes up that's important for people to understand. First of all, NIMHD, unfortunately, is one of smaller institutes at an age. Don't quote me, but child health is really something. IMHD is $1 million. So it really is a dramatic difference in resources that they have available. The second part of this is that LGBTI health is not yet officially declared as a health disparity. And NIMHD has very strict provisions as to what they are to support related to the official declaration of what is or is not health disparity. Now, I can see beyond this table, probably eyebrows are being raised because no doubt in your everyday lives, treating your patients, dealing with your family, your friends, perhaps your own health, you would argue that these populations do have health disparities. One of the challenges has been the paucity of data. And so at the very time that we are examining, and there's actually a very formal process of how that examination is made. It's an analysis done by the director of HRQ, the director of NIMHD, which then gets reported up to the secretary of HHS. So it's actually a very formal process. Very time when that analysis is ongoing, sadly, we lack some very, very basic data to make the case, to make the argument. And so we are a bit of a conundrum. On the one hand, saying we need more data to make the case, but on the other hand, we just start thinking we need more support to get the data. I don't exactly know the way out of it, but it is being deliberated about, and the deliberations are being informed by the data we do have. But part of the challenge that we all face is the plural of anecdotes not made. And so whilst all of us, myself included, and point to members of the LGBTI community clearly have suffered traumatic and see patterns apart from obviously we don't have the public. So there is this conundrum. We are working with immigration. So that in part explains why you see probably not the most satisfying answer.
Yeah, but I think, as a field, we're happy to sort of point to that data that is available. As you mentioned, there's the special issue of AJPH coming out, looking at the available YRDS showing dramatic disparities across pretty much any health we could look at. And there have been a number of reports, and we're happy that, Healthy People 2020, LGBTQ health disparity population. So I think it's to the extent that we in the scientific community to help make that case is very possible. On that.
Yeah, and again, I think the conversation, pointing to more recently published works, all of that adds to the body of knowledge.
Okay, so let's open it up again. Keep your comments to a little less than 5 minutes, so that would be great.
Okay, great, thank you. Good morning, everyone. My name is Joy Messenger. I'm the Deputy Director of the Illinois Caucus for Adolescent Health. As an organization, we're committed to supporting the sexual health rights and identities of young people, and we do this through education, organizing, and advocacy at the cultural and legislative levels. I speak from the perspective of somebody who uses and helps disseminate research and data to folks throughout Illinois, the healthcare systems, school systems, family service systems, and also really interested in bridging the gap between the academy and the community. So my comments today are both for the NIH, but also to any of the investigators in the room, as we are a community organization that works successfully with young
people and are interested in building more research in this area. I'm actually I was really excited to hear a number of folks make comments and recommendations about increasing the breadth of adolescent LGBTQI research, and also seeing from the perspective of the importance of families. At IDA, the Illinois Conference of Adolescent Health, we know that families are really important to the young people we work with, whether they are LGBTQ identified or not. And we also have broadened our research and our work into looking at the importance of chosen families. And so I know from within public health, within social psychology, and some other fields, the social network research is really important. We want to push folks to broaden that into thinking about chosen families. This year we did research that found that 73% of young people talk to their chosen families about sex and sexuality, while just over half are talking to their chosen family, talking to their given families or their families of origin. And when we broke down the data related to sexual orientation and gender identity, we found that those folks were increasingly more comfortable talking to chosen families rather than families of origin. Another issue that I wanted to bring up was the need for more research on innovative and comprehensive sexuality education. Here in Chicago, we know that chlamydia, gonorrhea, and syphilis are number 1 and 2 amongst young people in terms of transmission, and so I was really surprised, or maybe not surprised, by the numbers related to the funding of HIV/AIDS at 82.5% versus all other STIs and herpes at 18.5%. And so I think part of broadening the base around sexuality education is increasing the research dollars that are known to talking about other sexually transmitted infections, as well as talking about how to decrease the stigma and shame that surrounds sex and sexuality, and not just focusing on disease prevention and teenage pregnancy prevention. One other thing that I wanted to mention was I really enjoyed your comment that every voice counts and every voice matters, and I would like to push both the investigators and the NIH to support research that sees youth as co-investigators. So in traditional CBPI and persistent story action research under the age of 18. We know that this can increase the relationships that we have with the community, and keeping with that theme that every voice counts, we fight for the fact that nothing about us can be done without us, and that youth deserve to be at the table for the research being done on them, and deserve to be having a voice for people working with them. And then the final comment I wanted to make around sexual orientation and sexuality was just increased research on asexuality, and focusing research on asexuality as an identity rather than a pathology. And so those are my comments. Thank you very much.
So the next speaker is coming to the podium. Just one slight point of clarification. The data I showed related to sexually transmitted diseases was only that which is related to LGBTI communities. The amount of research that NIH supports on sexually transmitted diseases overall is quite substantial. So I hope that we didn't mislead anybody. And thank you for your comment about youth as a research partner. That's very interesting.
Hi, thank you so much, Dr. Jaya, for being here. My name is Dr. Michelle Burkett. I am a research faculty at the Impact Program at Northwestern. I hope to make a few comments today to sort of reiterate, highlight some of the really important things that stood out for me and maybe say a few other things again. The first thing I wanted to talk about was the methodological issue, which I'll just data collection analysis. Like many people have said, particularly today, there's just not enough data out there. And one of the issues with the lack of data is especially the lack of data around population-based data, which is so important. We're really interested in comparing disparities between sexual minority youth and heterosexual youth. There's a huge need for those data, and there's just a lack of measures out there that are being included. I think we talked a little bit today about how some data are getting there. So YRBS is one that several jurisdictions have. So we have a full data set of from 2000, 2005, 2007 of 14 jurisdictions. That's like 70,000 students that we pulled together. That's what we did for the analysis of the special issue of American Journal of Public Health, which is wonderful. It's a very creative use of the data that's available, which I think is what's really necessary right now. I think another creative use of data would be to be pushing for large cohorts that have been collected without sexual orientation identity measures. They're still being collected, active source of cohorts that are being followed. Why not include sexual identity, sexual behavior in those cohorts right now and be able to look over time at what the health was like of these individuals they were out of us. That might be a way of kind of creatively getting at that data in a way that's quick, I guess. Another thing that I think the problem with not having this data is that you are really missing some populations then. If you don't have this population-based data, you're missing especially adolescents, and especially missing older adults. I recently went to a meeting several weeks ago where researchers who were in charge of a large population-based sample of older adults were very worried about including measures of sexual orientation and identity because they thought it would be very offensive to their cohort, which I think there's enough evidence there that it's not necessarily offensive. There's actually several other presenters at this meeting who were presenting research, similar research with older adults who did very well when presented with sexual orientation measures. And so I think there's a big case to be made that this is something that's important, should be pushed more, some education needs to be done for why it's important to be including this, and that actually people who might actually appreciate being asked about their sexual identity, their sexual orientation, their sexual behavior. Because older adults and adolescents do have sex, and do have sexual orientation.
Just to keep on time, if you want to make one final.
Sure. One final point would be that it's really difficult right now. We kind of talked about this a little bit earlier, but I think what's really important is that it's difficult right now to have funding of LGBT research split across so many different centers and institutes, and not having one central sort of location. One reason for this is that what, as a researcher, we end up doing is really focusing on an outcome, which it can be very frustrating when it's not really the outcome so much that you have to be interested, but the mechanism and process. And so not having room for things like homophobia and minority stress to really be examined. We might just treat a symptom, but not really the problem. And I think it's particularly important for us, we're interested in LGBT research, and we're funded by the NIH to have given those opportunities to obtain training grants and research grants focused on, especially training grants, because we are so research focused, and it's very hard for us to take on trainees that would really benefit from this sort of training, or at least the infrastructure to support these trainings. Thank you.
Thank you. So as the next speaker is coming up, I just offer a comment to all of you. So NIH, in addition to the institutes and centers, which we're all very familiar with, NIH has something called the Common Fund, which is designed to support research that cuts across all institutes and centers, and it's supposed to support work that optimizes the interface among the institutes and centers. And they have different funding opportunities. And in particular, there are some really career awards which really persons might be interested in. Called the Military Award. Where you need very little military data. The emphasis is on the idea, not the military data. It's totally connected with that. And so, in addition to interrogating the various institutes and centers, you might also look at the Common Fund as another way of supporting some of the cross-disciplinary, interdisciplinary types of work.
Hello, good afternoon. My name is Kareem Watts, and my professional affiliations, I'm the research manager at the Interdisciplinary Center at the University of Chicago. But I'm here today specifically to speak from the community voice as a former community co-chair for the Alliance for Research Chicago and Community Park, which is housed here at Northwestern at the Center for Community Health. Particularly one of the issues that we as community partners who sit on this alliance that we're constantly faced with is how community partners are at the table This has come up in most of the presentations today, but I wanted to go on record to just really indicate the importance of having community partners at the table at the review process. I was very pleased to hear you talk about the way that there's new pipelines for increased number of NIH funders to the review table, but I want to make sure that we have a strategic way to get community partners at the table, like as was spoken earlier about youth at the table, but also community partners at the table for the review process. And also for the NIH to think about, because there's many community-engaged researchers, many of whom are sitting in the audience today, but there's many community-engaged researchers who are actually limited in how they can involve community partners because their hands are tied in the way the funding structure has to be disseminated to community partners. Many investigators want to do more to get the community partners involved, but the way that they can support that, fiscally support those community partners is often limited. So at the NIH level, I want to all be very strategic in how we think about, one, getting the voice of the community partners at the table when those grants are reviewed, because we want to move beyond just a simple letter of support and really having the community partner there as we think about designing a more community-based participatory model, but also thinking about how some of that funding can actually go to the community partners. There's a lot of investigators who actually want some of that funding to go to community partners in a strategic way, but they're limited in how they can do that. Thank you. Thank you.
Hi, my name is Raven James. I'm an assistant professor at Northwestern State University in South Chicago, teaching focused university. I teach international health sciences and addiction studies in behavioral health. The research that I did, just some quick background, originally from upstate New York, worked for an HIV organization for 8 years as assistant director of profession and education. Did a lot of work under OASIS, New York Office of Alcohol and Substance Abuse Services, clients that were HIV positive and substance abusers. So the research that I've done here has been primarily with women, but I found some salient variables that are linked to sexuality and sexual health for women in treatment. There's also a high prevalence of bisexuality and bisexual and lesbian women that have substance abuse problems that end up in treatment. Treatment providers are often reticent to talk about sex and sexuality. And what I observed when I worked in the field is that most of the sexuality information that people got in treatment was HIV related. So it's kind of an incomplete approach to looking at sexual health. With the study we did out here in Chicagoland with over 251 women, about 26% of our sample was bisexual, lesbian women, mostly bisexual identified. And some of the variables, the women who spoke first with our group talked about sexual shame as a salient variable, and that was one of the big contributors that we found with our bisexual women that was linked directly to their substance abuse. You also look at other health disparities that are linked to substance abuse, sexual abuse, reproductive disorders, low birth weight, body cancer, which is linked to body image. But the whole idea is that integrated comprehensive approach needs to be included as part of the treatment process. So funding, I think that would be helpful, in particular, would be that required or somehow required training in counselors. We look at counselor training, K-curve just moved from 48 to 60 hours, and some of the programs that I taught for, none of them included any sexuality courses in their curriculum. So required training for counselors is critical. We're going to have people that have the ability to talk to their clients, effectively help their clients, be culturally competent with their LGBT clients in substance abuse treatment. We know that we're going to see larger numbers of clients in treatment with substance abuse. And when you can focus, you say the substance abuse piece, with the funding attached to HIV. So I had to really be careful when I framed my RO3, which is waiting to be reviewed, to include an HIV component with that. But the missing piece is that you can't just give education. You need to look at the activities and all the other variables that are linked to why people are at risk for HIV and health disparities, particularly in the LGBT community. One other area that I think would be important.
Just for the sake of time, if you want to wrap up.
Okay, one more. So it would be helpful to have more program announcements, again, that are specific to remind us for LGBT research, behavioral integrative therapies development, PA, and the gender and sex differences, that there could be one specific to
LGBT, and also infrastructure funding for universities such as mine, building capacity students, faculty, and staff to do this type of research. Thank you. Thank you.
Good morning, I'm Michelle Burns, and I'm a research assistant professor with the Center for Behavioral Intervention Technologies here at Northwestern, as well as the Department of Prevention. I'd like to draw attention to a specific issue in the new health that might be mentioned earlier of mental health research for LGBTQ that's not necessarily tied directly to HIV as an outcome. Specifically, I'd like to talk about the need for research on the development and evaluation of accessible treatment models for depression, anxiety, among LGBT youth. So as far as the scope goes, there have been studies showing that sexual minority youth, specifically male youth, have higher depression and anxiety symptoms than their heterosexual peers. Diagnostic research is more rare, but one analysis I've worked on in conjunction with the IMPACT program on data that they collected from 450 young men who have sex with men in Chicago was that a third of them had lifetime prevalence of major depressive episode. Of that third of the participants, a third of them, 18% of the sample had MDE within the past year. Of those folks, a third of them had gotten treatment, the rest had not. And a third of them had desired treatment, but had not. So if we think of all the barriers that adults face to mental health care, such as problems with having a care system where they're comfortable, as well as insurance and whatnot. Youth also have additional challenges, such as bringing up issues related to sexual orientation if they're relevant to mental health concerns like providers. And so, just trying to keep it brief, we also are not sure the extent to which existing marriages seems to be culturally tailored for these. And so, I'd like to make a plug for accessible delivery models.
Good morning, thanks for this opportunity. My name is Trent. I'm the Director of Prevention Advocacy and Gay Men's Health at the AIDS Foundation of Chicago. And in my work there, I focus primarily right now on biomedical prevention, so research advocacy, communication, education. And in that, I share a group called IRMA, International Rectal and Herbicide Advocates. So my couple of comments are going to be coming through IRMA lens, or the rectal lens. First of all, I'm glad to hear more interest around anal health. I think we need to do much more. As we gain expertise, our knowledge base isn't being translated out into the world. Most places around this country, you don't know about anal paths for all people, and don't know what to do with that normal anal paths, or don't know how to treat it, or don't have the capability of treating it. That's a huge problem in most places in the country. Luckily in Chicago, that's not the case. So yay, anal health. Number two, big thank you to NIH for funding the lion's share of rectal microbicide research, 90+% over all these years. So that's really huge. Thank you very much for that. Please continue. The field just launched its first phase 2 rectal microbicide trial. First one that's ever left the United States, so it's a really big deal. And we get a little concerned in the advocacy and scientific community when we see articles, leadership at NIA that talk about all the other things, preventing pre-exposure prophylaxis, circumcision, treatment, cure, vaccines, all great stuff, but they forget the M word, microbicides. Just want to make sure that NIH is still on that, even though we've had some disappointing results on the vaginal side. That said, I think a rectal microbicide that can be delivered as a lube, an enema, douche, or a film would be fantastic. And what we're really excited about in the field is seeing things that can be used in both compartments, so something that can work vaginally and rectally would reduce the issues that women have with multiple tubes and lubes, and make it easier for gay people in much of the world who can't identify, who don't want to identify as having sex, to be able to pick up that lube that isn't branded with a big rectum on it. Finally, that would be interesting branding. Finally, the last thing I'll say is, many people in this room probably don't know that lubricants that we use for sexual behaviors right now aren't tested for safety in human beings. They're
tested in animals, and then they come out to the market. And there's been some curious and concerning studies over the last couple of years that have raised red flags about the safety of sexual lubricants, of water-based lubricants, that are actually causing damage in animals, causing damage in cell lines. There's only been one human study that's ever looked at lube safety, and so I think this is something that NIH and would benefit all people who use lubes, regardless of your orientation or your identification, to put forth a lube safety research agenda to determine whether or not some of these lubes that are very popular, hyperosmolar, water-based, they work well with condoms, but they may be causing problems to tissues, maybe enhancing HIV/STD acquisition. It's a big concern. We have to answer the question, so I hope the NIH would consider that. And if NIH is interested, we do have a draft lube safety research agenda that scientists and advocates have put together. So at any moment, if you give us a call, we'll return. Thank you.
My name is Laura Cooper, and I'm a graduate student, actually affiliated with Impact, a clinical psychology student. So I just want to make kind of one broad global comment. My research is mostly on trans youth and youth development, health and development. And as much as I appreciate and am enthusiastic about NIH's mission and all of these efforts that we've heard, one thing that really is always kind of in the back of my mind is, I see NIH as a government institution, and government institutions are one of the largest perpetrators of violence to trans communities, and particularly around policing and incarceration, the prison industrial complex. We incarcerate more people than ever in the history of the world, and more than any other country that exists. Also, things like government documentation, so being able to access, these documents that reflect your sense of self, Medicare, Medicaid, lack of healthcare options, transferring healthcare options. So when I say violence, I think of the physical violence that gets perpetrated every day by police and people in power in the government against trans people, but I also think of just all the marginalization and difficulties and barriers that come up for trans people that are directly a result of government systems. So I think that's one of the kind of challenges I see for kind of the government and these larger institutions tackling these issues, is recognizing that they're also the ones that are perpetrating a lot of the violence that continues. Thank you.
Okay. So we like to think of ourselves as the good people in government. So there's been some common themes this morning and this afternoon. I am struck by how so many of you reflected on the sort of ecosystem, starting with the family unit, whether it is defined as a couple or as a parent-child unit, parents-child. Quickly jumping from that to the more community-based approach and how you link those sorts of things. We heard a lot about community participatory research, and that may in fact reflect the strengths of your team and interests of your team. But so much of the on-the-ground work that is being done with the LGBTI individuals, of course, community helps in this sense. Community participatory research is supported by NIH, but it is not the largest investment giving, obviously. And again, investigators need to make the case in part by crafting and conceiving novel applications that embody these types of things that you all express such powerful statements about. Don't just wait for a funding opportunity. Fundamental principle of grantsmanship is don't apply, you don't get the grant. And that may sound silly, but I have found particularly less seasoned researchers who have not had very good experience with it, that you sort of are guided perhaps too much by urban legend or urban myth about what won't be funded, what won't work. Sometimes you just have to take a chance, and it is a chance. It's a tremendous amount of work. Sometimes you have to take a chance to put out your best ideas, you and your colleagues. And I certainly do that in consultation with the program staff, but I would urge you to at least consider that, because that's how new ideas, new approaches are born very often, based on what we receive from investigators. That's why 70% of what we do is investigator initiative. We really don't have the answers. And in terms of partnerships, we do want to be a research partner. We still have to learn how best to do that. Each time we have a listening session, we learn a little bit more. But we do want to partner with you. We do want to try to enable you to succeed at your mission, your goals. And I do want to thank all of you for being here. I know this takes a big chunk of your day on the all those emails. But and for any additional suggestions or concerns, please use that email box that I put up in my presentation. I'm told to distribute all the participants. That is my staff, and we will take those considerations.
I know I'll take the privilege of the organizer that a colleague of mine, Dr. Matthews, wanted to make, I guess, putting remark, a very short one, so what part of it all wrap up.
Trying to be late to the party. Public speaking is one of my favorite things, so I was trying to talk myself out of saying anything, but alas, here I am. A couple of three very quick points. The vast majority of what we know about LGBT health that's outside of HIV-related work is this big. And what is known in those other categories is primarily descriptive. I want to make a plug for really establishing a pipeline around intervention development in areas that are outside of HIV and AIDS areas. There is a lot of tremendous amount of data that suggests that health disparities exist across the board, and that we need to start doing work around it. So, one, establishing a pipeline specifically around evidence-based intervention development and dissemination of topics other than HIV/AIDS. The second is to go for low-hanging fruit. That is, we have come a long way in insisting that researchers measure questions, include questions about gender, around race, ethnicity, to accelerate the scientific literature on those other disparity groups. I think it is extremely low-hanging fruit to have a requirement of including sexual orientation and gender identity as standard demographic characteristics collected on all NIH-funded grant applications. And then thirdly, back to the original point around intervention development, there's an open question in the field around the relative benefits of both tailored and non-tailored approaches to health promotion approach in LGBT communities. I'd like to advocate for a convening of a think tank around scientists to determine what would be those primary characteristics on which we might want to consider tailoring a broad range of interventions. All right, I'll go away.
Well, I know that I'm so appreciative of all of the feedback that everyone was given, and I just want to convey on behalf of all of us our appreciation to you for coming. You know, we started out by talking about the fact that not too many years ago, even having the word gay in the title of an organization was revolutionary, and to now have such a senior member of the leadership of the NIH here with us to really listen to us and hear our perspective is really tremendous and something that I'm so proud that we were able to facilitate. So please join me in thanking him for much immediately. It's probably already early to the airport. So thank you so much for coming. We will be having lunch in the atrium immediately following us for the box lunches. We did set up some table markers for different topical areas to facilitate networking. So if you do work in a particular area and you want to sort of affiliate with people in that area over lunch, look to the topic area. Of course, we can cover all the topics, so there's also some tables without markers you're welcome to work at. And if you're signing up for continuing education, it will be available on the registration desk. And you need to sign in before the research sessions begin at 1 o'clock. So thank you.